Thank you. The gentleman yields back. The chair now recognizes Mr. Cardenas. The gentleman from California, Mr. Cardenas, for 5 minutes for questions.
Thank you, Chair Guthrie and Ranking Member Eshoo, for holding this timely hearing, and thank you to our witnesses for sharing your expertise and your opinions. Emerging AI technologies show an incredible promise to improve and plug gaps in our existing healthcare ecosystem. Many of you have already mentioned that these novel technologies have the potential to expand healthcare access, address outstanding disparities, and support the healthcare workforce. I've been clear in my support for advancing technologies that increase access and quality of care for all Americans. But there's also the potential for harm if we're not intentional about how to proceed forward. AI should make healthcare systems more equitable, not less equitable. And because AI is only as good as the data it trains on, or I worry about the possibility that these technologies may perpetuate or even widen existing health disparities. We have a responsibility to ensure AI innovation in healthcare is developed carefully and reliably if we truly want to harness its full potential. I have a question for Dr. Newman-Toker. Dr. Newman, you mentioned in your testimony that those in rural or underserved communities or those with social determinants of health associated with generally worse health outcomes may be most susceptible to suffering adverse consequences of inadequately regulated AI systems. Can you expand on the kinds of consequences we have already seen?
Yes, obviously we have populations that are at risk. These are individuals who do not necessarily have good access to healthcare in the first place. And on the positive side, we hope that AI will offer the opportunity to deliver higher quality care, greater access to expertise. On the downside, there are obviously concerns about whether AI systems will either be accessible to those individuals at all. For example, there may be broadband access problems or other issues that constrain their ability to even access technologies, even if they're broadly available. And we have further issues about health literacy, the ability to use such tools, and beyond that, the issue of whether when AI systems do potentially fail or make errors, they may be less equipped to be able to deal with those problems.
Thank you. What should Congress keep in mind as we look to AI to improve health equity and protect against worsening disparities? Yes, go ahead.
I appreciate your question. We've talked on this panel about the importance of transparency, and some of our vendor colleagues talked about submitting to the FDA the results of internal testing. But it's important for this subcommittee to recognize those are all self-reported tests. And so the Coalition for Health AI, or CHAI, has recently proposed a series of national labs that would serve as testing beds for vendor-supplied AI algorithms. I think that's something that should be reviewed in more detail, because having an external testing is the way that we're going to mitigate these health equity kind of issues that come up from algorithms developed on biased data sets.
Thank you. One of the things that I'm concerned about, we've seen in the past with incredible innovations that make it easier for people to make conclusions. For example, back in the day when the term credit score didn't even exist, I was told at the time when I said, wait a minute, you're going to use this as not the backdrop, but you're going to use this as a primary driver of who is going to get access to capital across America and now across the world. And they said, no, it's just a side tool. No, it is now the main tool. The old days of having a big file and having a whole review before they make a decision is gone. But my point is this: they are proprietary algorithms. The government of the United States doesn't even have a clue what those algorithms are. Nobody does but the actual proprietor, and it's protected. And I respect that protection because they've done a lot and invested much into that. So it is, in fact, proprietary. But the problem is this: nobody knows what's happening in that black box. That's one of my concerns with AI, especially when it comes to not only quality of life, but whether or not who lives or dies based on an algorithm's decision as to what is going to be the outcome or the cure, or if someone is even going to get access to healthcare because they say, no, yours is not an emergency situation, so therefore you're not going to get cared for.
We 100% agree with you, and we see the increasing rate of denials of payer claims, and we know that that's being driven in part by AI processing these claims and very rapidly denying them in an inequitable way, and so we share your concerns.
Well, we already have concerns, we already have examples, and I hope that we in Congress actually do our job and actually try to move, hopefully as fast as AI has, in order to make a better future for us. Sorry that I went over my time, Mr. Chairman. I yield back.
Gentleman yields back. The chair recognizes Mr. Gentleman from Ohio, Mr. Latta, for 5 minutes.
Well, thanks, Mr. Chairman, and thanks to our panel for being witnesses today. I tell you, it's very, very important because AI is something that I applaud our chairwoman, the full committee, through all of our subcommittees that we've been having hearings on AI and how important this issue is as we go forward, especially when we're talking about on the healthcare side, because this is especially technology that we do have to put those guardrails in place, making sure that we protect the privacy of Americans and also prevent other countries, especially countries like China, from abusing it. Also in this subcommittee, it's also been interesting through the years, and it's been brought up in your discussion today. Again, we were trying to help the providers out there being able to do what they're supposed to do. You know, we have a shortage of healthcare providers. The docs that we've had before us today, when I've asked them questions, I remember one panel especially, I said, I think about as many as at this table today, I said, how much time are you spending actually seeing your patients? And I don't think one of them said more than 50%. And so when you have a shortage of doctors out there and nurses and everyone else, it's important that they're doing that job that's actually essential to get it done. Dr. Newman-Toker, in 2021, more than 100 drug and biologic applications included AI and machine learning components. Would you explain to the subcommittee, if we continue to explore AI, how this could lead to further breakthrough developments?
Thank you, Congressman, for the question. What I would say is that as we look to the space of drug development, you can imagine in the same way as in general with healthcare, that there are opportunities for AI to help both in the process itself, that is the mechanics of working your way through the regulatory process, as well as through the identification process of actual treatments. So, for example, if we have large data sets that allow us to identify drug therapies that are available to us, then I think that will give us an opportunity to break new ground using existing data architectures.
Yeah, well, thank you very much. Dr. Schlosser, when I was reading your testimony, it was kind of interesting. I got a question because I thought it's kind of interesting when you the technology uses the ambient speech models to transcribe the doctor-patient interactions into text in emergency rooms. And because, you know, we all have the opportunity to visit our hospitals, and especially because being on the subcommittee, I go through a lot of different emergency rooms, and, you know, the stress that happens there. I'm curious, because of the stress and everything that's there, how does the technology eliminate that stress to make sure you're getting the perfect, absolutely 100% of what you got to have to be transcribed for that patient?
Yeah, well, and thank you for the question. And I'll go back to a comment I've made several times now, which is the human in the loop, and that we always have the physician and their opportunity to review the note as that last step before it would ever become part of the electronic health record, so that they can ensure that it is 100% accurate. The AI is not at the point yet where it can do that completely on its own. We're using the data through data sharing agreements to continue to improve the quality of the AI, and it continues to get better and better, which means it saves them more and more time. They have to do less editing at the end of the event. But right now, we do need those physicians to still be vigilant. As you identified, the emergency room is a chaotic and challenging environment. That's actually why we took that technology there in the first place. We feel like it has the most to offer in that space, where precious time given back to the physician so they can really tune in to what's going on with that patient will actually yield meaningful quality results.
Well, thank you very much. Dr. Longhurst, you said something interesting in your testimony. You said that we have to have the ethical review of AI. Would you just delve into that ethical review of AI a little bit more, please?
Yeah. So our Health AI Committee, which has been around for some years, is staffed by legal and compliance and risk management and clinicians. It's co-chaired by several of our internal medicine physicians. It includes health equity researchers and bioethicists. And the reason for that is to look at things like, what is the ethics of being transparent in this case? Is that an ethically appropriate thing to do, or are there ethically challenged questions? And so that actually helped to raise for us when we first implemented generative AI to help our clinicians respond to patient messages. That question was raised by our ethicists: should we be transparent with our patients? And that generated the conversation that resulted in full transparency to our patients about the fact that we were using generative AI to help with our responses, even though there's still a human in the loop, even though those messages are still edited by clinicians at the end of the day.
Well, thank you very much, Mr. Chairman. My time's expired, and I yield back.
Gentleman yields back. Now recognize Dr. Ruiz from California for 5 minutes.
Thank you, Mr. Chairman. Our healthcare system is strained by widespread healthcare workforce shortages, burnout, and barriers to care for patients. As members of Congress, we must work together to create a healthcare system that is sustainable, fair, and always puts the patient first. It is important to not only support advancements that improve patient quality of care and strengthen the workforce, but also ensure that we are addressing barriers to care that affect underserved communities, communities that need the care the most, due to the disparities of health and the burden of those disparities on those communities. As the witnesses here today have underscored, innovation in AI has the potential to address these concerns and improve patient care. However, these technologies also pose potential risks that we must carefully consider and mitigate as the technology continues to develop. As an emergency medicine physician, I am all too familiar with the administrative burden that physicians face and the negative impact that can have on patient care. Dr. Schlosser, how is AI currently helping physicians cut down on administrative burdens so they can focus their efforts on patient care, and how does this affect the quality of patient care?
Thank you for the question, Mr. Ruiz. And I agree completely with your comments about the burnout and administrative burden that our clinicians are seeing. As I just mentioned and mentioned in my testimony, we focused in two areas. One is around documentation improvement. Documentation takes up an inordinate amount of our clinicians' time, and if we can return that time to them so they can focus on patients, on underserved patient populations, we believe we can actually create an expanded healthcare workforce using just the clinicians we already have by simply automating and removing some of those tasks. We're also looking at AI as an assistant to our nurses. Our nurses are under the same kind of pressure our physicians are from shortage and burnout. And so giving them tools that helps them do their job, like the nurse handoff tool we talked about in the testimony, where we can automate a piece of their workflow, making it easier for them to spend time at the bedside with patients. We think both of those will lead to improved experience and bring some of the joy back into caring for patients.
Thank you. Dr. Nguyen, your testimony mentioned specifically how Transcarent uses generative AI in your virtual clinic. What safety mechanisms are in place to protect patient safety when using generative AI in health settings?
Absolutely, yes. To clarify, generative AI is still being prototyped internally at Transcarent. We do use non-generative AI in our clinic. Safety mechanisms, though, to consider when you are building generative AI or any AI applications really involve safety at every layer, right? So when you are building these systems, you need to think about the data layer first, right? And ensure that you don't have a garbage in, garbage out system problem in your system. You also need redundant safety mechanisms. I mentioned earlier the use of narrow versus general AI systems. You want to build redundant safety mechanisms that can detect things like patients asking questions that indicate they might have a medical emergency, right? You want those specialized systems in place, ensuring, right, that you have a high degree of likelihood that you're going to catch issues like that. And so, you want those redundant layers in order to ensure the highest level of patient safety.
Dr. Newman-Tucker, what would be the ramifications of AI biases in health care if it is not addressed at this point in AI development? And what strategies should be implemented to detect and mitigate biases in AI models used for healthcare?
That's a great question. Thank you, Congressman. What I would say is that obviously we don't want to concretize the racial biases that we see and other demographic biases that we see in human behavior today in the form of mathematical algorithms. To prevent that, we need to do work both on the side of developing the AI tools using appropriate data sets. We also need to deal with, at the back end, monitoring for these kinds of problems, both using sophisticated tools to identify bias, as has been done in a number of recent studies, and furthermore, to monitor for outcomes of healthcare associated with AI so that we can monitor for measures that matter for patients who are underserved.
Thank you. I appreciate that. Thank you all for your insight into the benefits and potential risks of using AI in healthcare. This insight is especially important to ensuring this innovative technology is used to improve patient care, improve access to care, reduce healthcare disparities, reduce the barriers in underserved communities, and improve equity by giving resources and healthcare attention to locations that need them the most, while mitigating biases and potential risks to patients. And I yield back my time.
Gentleman yields back. Now recognize Mr. Griffith for 5 minutes.
Thank you very much, Mr. Chairman. I appreciate it. Dr. Longhurst, I'm going to pick on you first because I loved this book, The Perfect Predator, which was written by one of your colleagues. And so my question is, and for those who don't know, it's about phage therapy and the saving of her husband's life, Thomas Patterson, who also is a UC San Diego individual. By finding the right virus to attack the antibiotic-resistant bacteria that had attacked his body. It's a great story if anybody wants to read it. The question is, are you all using AI to try to find more of those phage therapy-type viruses? And if not, do you see any potential in that?
Great question, and thank you for referring to the book, The Perfect Predator. It's an amazing story of a life saved by phage therapy. Something that was actually explored prior to the advent of antibiotics, and now we've gone back with antibiotic resistance to looking for solutions outside of that domain. And so it started a whole movement across the world. We do have a center at UC San Diego pursuing expansion of phage therapy for treatment of serious bacterial infections. I am not aware that we're currently using AI to help with that center, but as previously mentioned, I think in general, drug discovery will be augmented by the use of AI, and I'm very optimistic that we're going to see large language model generated hypotheses about new ways of treating patients that we may not have previously examined hypothetically. So thank you.
And that was a little bit off script. I'm going to go back to script, but it's I'm going to flip the coin over on the other side. According to reporting, the use of artificial intelligence has the potential to allow for generative large language models like ChatGPT and other chatbots to revive old deadly pathogens. So we've talked about how it can help. It can also be used to revive old deadly pathogens or even create new deadlier ones. One example was done at MIT, where students were able to get the large language models to suggest 4 potential pandemic pathogens within 1 hour by asking a series of questions to a generative large language model. Further, researchers in Cambridge, Massachusetts used open source large language model, asking it how to revive the 1918 Spanish flu. Several participants found obtaining the 1918 virus Spanish flu would be feasible for someone with basic wet lab skills, while one participant got very close, in quote unquote, very close to learning all the steps needed to obtain the virus. So I'm going to go to you, Dr. Nguyen. I was encouraged to see the White House put out an executive order to attempt to provide more oversight and security on this type of AI, but this still causes grave concern. Do you know if any AI technologies have security limits on what can be asked and what cannot be asked?
Thank you, Congressman. That's a very good question. In a broader sense, even outside of healthcare, right, these AI technologies have extremely broad and wide capabilities, many of which we don't fully understand yet. While this is outside the realm of the kind of AI Transcarent uses, AI in general, especially generative AI in the large language model sense, in that field there is the world of alignment research, right? The world of alignment research refers to the science of studying the malicious capabilities of these models and studying the ways in which we can defend against them. So in that world, right, very, very important work is being done to find things such as what you are describing, right, which is vectors of malicious use. There is still a lot of work to be done in that world, and I think it is very important for us in the healthcare world to follow that, acknowledge it, for this committee to support that kind of work.
So we want to look on the positive side, but one of the articles I was reading indicated that the proponent said maybe we need some kind of a test ban treaty like we do with nuclear weapons. Do you think that we should be looking at some kind of a limitation on the tests? I mean, we want the positives, but the negatives could also be very consequential.
Yeah, that's a very good question as well. I think it's very difficult to truly limit the progress, of testing these systems and making them safe without using them, right, and trying to push them to their limits, right? So I think it requires a measured approach. The other risk, though, of course, of test banning is that countries other than the United States will also,
Right.
make progress.
Right. I'm going to switch gears again. Back to you, Dr. Longhurst. You mentioned in your testimony the AI-based messaging system was helpful for virtual care visits and allowing doctors to provide more care to patients. Question is, did the patients trust the system and find benefit from those automated responses?
Thank you for your question. I know we're expired on time. I will say briefly that anecdotally we've gotten very positive feedback from patients, and we're submitting more quantitative data for publication.
Thank you very much.